Thank you again for having me, because this is really, I think, the joy of working together is going to be evidenced in these next couple of talks of how we can make a difference by working together. What we're going to talk about today is largely the National Partnership for Maternal Safety Hemorrhage Bundle and the CMQC, or the California Maternal Quality Care Collaborative Hemorrhage Toolkit, which goes along with that. After stressing the importance of obstetric hemorrhage, both for morbidity and mortality, no financial disclosures today. You saw this slide earlier, but just to reinforce the importance of hemorrhage as the predominant cause of maternal mortality on our units. And therefore, it is the first bundle out, both in California and nationally. Highly preventable, therefore, again, stressing the importance of our work. And again, the focus on provider factors, and specifically delayed response to clinical warning signs, both in terms of the volume of blood loss, the vital signs, and in delays in giving effective care, which we saw again and again. We had patients in our maternal mortality reviews that had 2, 3, 4 DNCs in a row without moving on to a balloon or to secondary medications. There was no plan to be followed. There was sort of random activity on the unit. So it is the most common preventable cause of maternal mortality, the most common cause of severe maternal morbidity, and a lot of quality improvement opportunities amongst all of the providers. So we put together a toolkit in California that had a collection of best practices. This is now version 2.0. It's been at the state for the state review for the last 6 months. And it will be released next week, actually. It goes along with the national bundle, which we're going to talk about in detail. So does this work? Does it work to have a comprehensive safety bundle on labor and delivery? And the bundles typically involve a way of semi-quantitatively assessing blood loss, doing risk assessment, and then having a formal plan to deal with it. This is a big hospital system that had good data collection in California called Dignity Health, formerly known as Catholic Healthcare West, led by Larry Shields. This was published last year after winning an award at the Society of Maternal Fetal Medicine meeting. And they looked at not the perfect design, a before and after design, but it's hard to do randomization of a whole implementation of these kinds of protocols. And there are a couple of important lessons here. First off, when you implement a plan for obstetric hemorrhage, you diagnose more hemorrhages. So you're not expecting to reduce hemorrhage, but if you have formal ways of looking at and quantifying blood loss and paying attention, you're going to have more mothers who have 1,000 ml blood loss. And you're going to have more mothers who you formally record and diagnose even 1,500 ml blood loss. And so those went up 37 and 77% over this study period. But what was really interesting is that the blood utilization went down. Okay? The whole point of the protocols is to be earlier active, to be reactive to in a proactive way with second-level uterotonics, femoral massage, and to be really use balloons more, move more aggressively along the treatment options that are available. And then if you are needing blood transfusions, that you transfuse earlier and with a balanced set of blood products that we'll discuss. And overall, you end up with significantly less blood products, 25% fewer blood products, even though there was more diagnosis of hemorrhage. So this has moved up into the national arena with the National Council of Patient Safety and Women's Healthcare, which includes vice president or president level representations from basically all the key organizations in our professional societies, including not only ACOG, A1, SOPA, ASA, but the Joint Commission. Actually, for hemorrhage, we had the American Association of Blood Banks. The birthing centers, there's several percent of births in the United States at birthing centers, and they have to be prepared as well as the federal agencies that are involved with healthcare and women's health, such as Maternal Child Health Bureau, CMMI, which brought the HANDS, the Hospital Engagement Networks, which in turn, this last 2 years, did focus on hemorrhage and preeclampsia after being part of this project. So we're going to talk about the first bundle, which is a working group that Barbara Scavone, Dina Goffman from ACOG New York, Lisa Kane-Lowe from ACNM, the midwife, Deborah Bings, Vice President of A1, from Family Practice, from Blood Banks, and from ACOG. We work together with all our organizations to work out a consensus bundle for obstetric hemorrhage. This is in press to be published in June in Obstetrics and Gynecology, Anesthesia, Analgesia, and the Nursing Journal, JOGGIN, as well as the Family Practice Journal will have at least an editorial. So this is simultaneous publication, which is groundbreaking to bring the evidence out. So what does a safety bundle look like? This is the fancy version of it with 4 domains. We're going to go over these a little bit more, but readiness, recognition, response, and reporting. We got alliterative there, so bear with us on that. This is on the council website now, as it's been for a while. And what the description we published in June is a lot of the fleshed out details of what it means. What is actually do we mean by bundle before I go on this? So this is not a national protocol. This is basically a checklist of items that we want every labor and delivery unit to have without being prescriptive about which protocol you should have. There'll be provided examples from New York, California, A1, and others that units should look at and adapt to meet their local needs, their local resources. But you need to have a plan. You need to have a series of safety items on your unit, and we'll go through what those are. So the readiness is about what every unit in the United States should have, is preparation for working with a hemorrhage. And this includes a hemorrhage cart with all the materials easily available, so nurses don't have to run this way, that way, the other way to find what you need. But this includes some instruction materials for how to apply B-Lynch or how to do a intrauterine balloon, because any single obstetrician may not have as much experience with these as you might, and these almost invariably seem to happen at 2 a.m. in the morning when we're not cognitively at our best. So reminder aids are, and they're in the same place. In this cart, you also have the protocols and the debrief form, so it's all centrally located. Units need to have immediate access to their medications. As we surveyed units in California, there were some units that had to go to the pharmacy to get some of these medicines that needed to be rapidly available, and others, it was a more complicated way of obtaining the medicines from their Pyxis or so forth. And we've learned, each unit has learned ways of rapidly accessing the medicines. Our response team, when we worked in our hospital through this, the nurses in the middle of the night were trying to figure out who to call and what their numbers were and who constitutes a team, that these are things that need to be worked out ahead of time with call systems. One of the key partnerships in preparation for hemorrhage is a strong relationship with your blood bank on 2 levels. It used to be when I trained at WashU and then at Penn, before moving to California, there was somewhat antagonistic relationship between our blood bank and the OB unit in terms of delays and people on the phone calling, you know, where's the blood, where's the blood, where's the blood? And that needs to be circumvented, and that's where you have the development of protocols for O negative, for emergency release, and you have good criteria for when you use those, as well as the working out a plan for a massive transfusion. When you get into the 2000 ABL blood loss, you really need to have plans that you can get multiple units at once, and we'll talk about ratios and things like that in a moment. But you need, so the blood bank needs to be your friend and an ally in the development of the protocols, but the blood bank is also a very good source of data, and that should not be overlooked. As we start getting into metrics around obstetric hemorrhage, Joint Commission and others are looking at things like how many women had 4 units of blood transfused, or how many total units you had. The blood bank has those numbers, and they're not in ICD-9s, they're not in other administrative sources. And those are good numbers to have for perinatal committees. Obviously, everybody of all flavors, all partners on labor and delivery need to be educated and have a common understanding of the plan. So what goes into a bundle are examples of what's in a hemorrhage cart or hemorrhage tray, example teaching materials, and example simulations and drills. So scenarios for these. So these are all on the reference websites and as a way of jumpstarting progress for these. We work very non-denominationally in California, so we have good collaboration with Kaiser, with Sutter, with Catholic Healthcare West, sort of, we have the Catholics and the Protestants all working together, and it works out quite well here. Because safety is one of those deals that you can share, even if you're economic competitors. We've been able to have a safety collaborative that supersedes all of that. So this is examples of checklists that you would have for a cart or a kit. And again, this is going to be changed from hospital to hospital, but you want to have a standard one, and you want to have a cart that you can pull into a room that makes everything go much quicker. The importance of this is the literature that suggests that even 10 minutes makes a big difference in a hemorrhage. It's all about getting it before it spins out of control, starts turning into a consumptive coagulopathy, that you do have a response time that is limited to minutes. So every ward teaches us lessons in medicine. The big lesson that has been, and we'll talk about the back and forth, the controversy about, but one of the big lessons that came from Iraq was the lowest level of losses from hemorrhage in any war that we've had. There were a lot of hemorrhages in Iraq from roadside explosive devices, and the Army went out of its way to have the ability to treat as quickly as possible with both red cells and fresh frozen plasma. And they published a series of articles that were able to show in a retrospective way that the losses were lowest when you had a near 1-to-1 ratio. Okay? So that became back as trauma surgeons returned, and this got published in the surgery journals, became more adopted in the United States, although not without controversy. And I think you may have had a lecture on that yesterday as to what the exact ratio should be, so forth. But nonetheless, the principle there is that you can't fully replace in a trauma situation or a massive blood loss, the blood loss just with red cells. So you have to be able to jump on it pretty quickly with some coagulation factors. And the principles that have evolved are whole blood equivalent, we no longer have whole blood, of course, is good for obstetric hemorrhage. And what's our protocol is that after 2 units of red cells, you start mixing in fresh frozen plasma with your red cells. And if you're still actively bleeding at that point, then you start down 1,500, you call upon a massive transfusion protocol, which, and the debate is out there about 1-to-1, 1-to-2. There was a very big article in JAMA this last year Comparing the two, and it probably didn't make much difference between 1 to 1, 1 to 2. And it's very hard to actually get to 1 to 1, but if you strive for it, you'll be somewhere between 1 to 1, 1 to 2. The Stanford protocol is 6 units of red cells, 4 of FFP, some are 1 to 1. But this is, again, when you're down in the 1,500 plus and still with abnormal vital signs. This is a jumpstart protocol, and then the second principle is that for hemorrhage patient, there are really 2 stages. The first stage, when you have abnormal vital signs, big blood loss, you're doing resuscitation. You're not doing it based on laboratory values. Those are sent, but those can be difficult to respond to because it's from a different time period and a delay. So some of that is being hopefully overcome with ISTATs and other rapid approaches, which aren't that necessarily widely available or may not still be representative of the hemoglobin that's still circulating there. So there's a resuscitation phase to achieve normal vital signs or near normal vital signs, and then you start responding to labs. So it's a double-sided message here for transfusion. The big difference in the last decade has been the emergence and the value of intrauterine balloons. This, very simple, is about $150, belongs in every single labor unit in the United States, and we've had very good penetration in California. I would say probably 95% of our units have these now. And it's basically Red Cross first aid. You know, if you have a bleeding site, you put pressure on it. The bleeding site in obstetrics, setting aside lacerations, setting aside DIC, is from the placental bed. Bleeding doesn't really happen in obstetrics until you start mucking with the placenta. It's when the placenta separates and the uterus hasn't squeezed down on the placental bed that you really start getting the hemorrhage. And so the balloon allows to put pressure on the placental bed. And where it's particularly useful is if the placenta had implanted, therefore the placental bed is in the lower uterine segment, which we know does not contract as well as other parts of the uterus. That's why we do a low transverse C-section there in the lower uterine segment, because it's not going to contract as much in the next labor. But you want the uterus to contract around the placental bed. So the Bacri balloon is a simple inflatable balloon that 3 to 500 mLs. It's silicone non-latex. It has a reasonable ovoid shape. There are now 3 other versions of this by other companies. They're all probably equally as good. Some are more complex, some are a little easier. There are little tweaks here and there. It does not matter. You need to have a balloon. And you, most importantly, should have one balloon so the nursing staff is comfortable with it, and you can train people to it. It does need some practice, however. One of the big things with the balloon is that if the cervix is dilated, the balloon will push out the cervix. And so oftentimes we need to pack the vagina to keep the balloon in the uterus. If you pack the vagina, with Curlex, there's the chance of leaving the packing in anytime you pack something. So what we have taught is that you tie the Curlex to the balloon catheter, because it stays in for 24 hours, and then when it comes out the next day, it may be a different provider that takes that out than put it in. So after a couple of our hospitals had retained foreign bodies from the Curlex, we really established that as a critical rule. So a balloon is one of the key second-line steps after oxytocin in a protocol. After oxytocin and methotrexate. The other operative intervention that should be widely available everywhere is a B-Lynch suture, a uterine compression suture. This is 90 seconds worth of surgery, assuming that you already have the uterus open at the time of a C-section. It's classically used for uterinectomy when the uterus is just a floppy, non-contracting bag of muscle. And it can be actually combined with pressure from the inside with a balloon as a sandwich technique. It takes a little practice to do, It's basically a belt and suspenders. You take the first stitch up and around like a suspender, anchor it in the back and come back to the front, and then squeeze with your hands and then tie it down. So then this is one that I did, that it gives you a squeeze down uterus as a compression effect. So we're really strong believers in situ drills. Besides doing a B-Lynch suture, there's not a lot of technical things that you have to do in a skills laboratory like you would for laparoscopy. This is really about teamwork and knowing where things are on your unit, knowing what happens when you call the blood bank, and you want to run through all those systems issues on your unit when you do a drill. Really important I think, to do it on your unit with your own staff who are working together and learning teamwork at the same time. Now, we talked about systems and L&D preparedness, but there's another piece here about patient level readiness. And obviously the big issue that many of our units have faced is placenta accreta or percreta, which is the bane of having a generation of many C-sections. So on your third or fourth C-section, this is a really big issue. And these are people that can consume 4, 6, 12, 20 units of blood. You really need to have a plan and a team in place. And it's probably one of the diagnoses that absolutely needs to be moved to higher levels of care. You do not want to deal with a placenta accreta in a small hospital with limited resources. Likewise, you have to have a plan for coagulation disorders. Von Willebrand's is the most common that we face in young women. But the one I really want to talk about is Jehovah's Witnesses. 25% of our hemorrhage deaths in California were Jehovah's Witnesses. None of them had a plan. None of them had a preparation for, by the medical staff, by the hospital staff, of what to do, how to, a plan for the pre-admission to raise the crit as much as you could, to go through all the choices. Jehovah's Witnesses is a big spectrum of care, of what they will accept or not. And you need to have those things sorted out and a plan for labor and delivery established before they come to labor and delivery. And then obviously in labor and delivery, it's a multi-specialty event. The anesthesiologist needs to be involved absolutely as early as possible and go through with the obstetrician and the staff the steps of what they're going to do, because this is where delay leads to death. You can get through, I was talking earlier today, taking care of Jehovah's Witnesses who had severe HELP syndrome and some that have had acute fatty liver. If you have a plan and are attentive, you can get people through very complicated situations. But it's one of the truisms in labor and delivery for any high-risk patient that the more you plan for it, the less the bad circumstance is going to happen. If you plan for it intensively, it's almost a guarantee it's going to go well. I won't write that check for you, but it's almost a guarantee it's going to go well. We do a lot for Jehovah's Witnesses with IV iron if they're not pushing their hemoglobins up with oral iron. There are now reasonable protocols to approach that. So the other big area is what to do for recognition and prevention. And here we have some controversy. This is what happens for every patient on arrival to labor and delivery. There are a number of risk screening tools for obstetric hemorrhage. We put out one. It's been validated at the University at McGee Women's in Pittsburgh. But it shows you that it validates it in that we pick up about 60% of the women who are going to have hemorrhages, but we miss 40%. Okay? And you identify about 30% of the women when you do that. So this is really more of a tool to say, to have a huddle and talk about this is a patient at higher risk. She has twins, she's prior postpartum hemorrhage, she has a number of the other key risk factors. you want to have everybody know about that, and you want to have those patients have the blood bank alerted and have the appropriate level of type and screen versus type and cross done. So it's more preparing for the care of that patient rather than doing anything specifically for her. The other time for a huddle is at the end of the first stage. When you're starting pushing the second stage of labor, there are a lot of things to talk about. You know, are you going to do laboring down? What's your plan for the second stage? And then that's a time we also briefly reflect on her bleeding potential. The two key labor issues that are associated with obstetric hemorrhage are prolonged labor and chorioamnionitis. Prolonged labor, either spontaneous labor or a long induction. When we noted that the postpartum hemorrhage rate went up in the United States over the last decade, and the transfusion rate, one of the big contributors was prolonged labor resulting in C-section. That's a combination that's at particular risk. So the beginning of the second stage is a good time to do a quick reflection as what the plan is and what's the bleeding risk. Now, the second point here is something that I'm sure everyone in the room has seen is how do you estimate blood loss? And we were trying, I was joking with one of my anesthesiologists yesterday when we had a 2,000 ml blood loss about, no one wants to call it estimated blood loss anymore. We were trying to call it quantified, or at least semi-quantified blood loss. What was this term? That was ABL. You want to avoid ABL, which is alleged blood loss, okay? And that's, the glance and the guess is what has been commonly done. Just look and see, oh, that's 300, or it's 499, one of those numbers, or it's 600 at C-section, and we can do better. There's a lot of studies being done about how to do it better, and I can't say that there's proof that weighing all the elements is better than others. There's a lot of new studies being done. One of my favorites, though, is to do, I think I have pictures here, of under buttock drapes that are conical with gradations on it. Now, obviously, at a vaginal delivery, where these are used, you have urine, you have stool, you have other fluids, amniotic fluid, but all those happen before birth, or before the placenta. And placenta, as we said earlier, bleeding happens when you start dealing with the placenta almost exclusively at vaginal delivery. So you can zero out those fluids and say, okay, after delivery, hand off the baby, you can look to see what's in the bag, and that's your 0 point, and then you can get a better estimate of what's going on. So it's being intentional. So formal intentional blood loss. Yes, we do like to weigh when you get into the bigger numbers, and you can do the same thing with canisters at C-section. Again, zeroing after you suck out amniotic fluid. But it's not going to be perfect, but it's going to be better than the glance and a guess. So this is a typical risk assessment. Again, none of these are perfect, but it gets people talking, and that's probably the most important thing. Now, the Association of Blood Banks has some new criteria that many of the hospitals in California have adopted, which is if the type and screen prenatally was not done at the hospital, then you need to repeat it. And so we're actually getting type and screens on everybody. And that is felt to be no increase in cost for our blood bank to do, and that varies along. So the response plan is a typical stage-based, how much blood loss and what you do for both thinking, for what you think, what you do, and how you assess. And a form or another of this should be in every unit, combined with a checklist. The checklist is just a reminder of things to do, like O2 SATs, which many labor nurses forget to do, or urimeters. And then this needs to be wrapped up, and is strongly supported actually by ACOG. There's two committee opinions that support this strongly in ACOG. because obstetricians have not been, shall we say, the first to rush to drills. ACOG has come out very strongly supporting the use of protocols and checklists for emergencies such as hemorrhage, and for the importance of drills and debriefs. These are two recent committee opinions that have come out for that. The other key element here is Toolkit resources for family and staff support. We're providing a lot of materials for how to talk to families after a hemorrhage or during a hemorrhage, and how to support our labor and delivery nursing staff and our physician staff. As you've probably seen, after a major hemorrhage, 10-unit hemorrhage, the staff is stunned as well as the family, and there needs to be support materials, and we've developed those as well. So this is about systems improvement. And what's really critical for systems improvement is that you learn from your experiences, and you have formal ways of doing debriefs. Debriefs are very simple, 15-second, 30-second, maybe 1 minute, what went right, what did not go right, what could we have improved, and then roll those into a multi-system or multidisciplinary, multi-system improvement committee. We have toolkit examples of these from several different sources. And now there are measures now to be following for this. So lots of resources, both at our website, cmqcc.org, as well as the national website, which often directs you to ours, so that works out okay. A1 is also doing this as a postpartum project. So I'm going to segue now.